Thank you for joining me again, and this time we're going to be covering the pharmacotherapy of COPD. As always, we like to base our teaching on evidence-based guidelines. And for COPD, you'll see that there's guidelines from the American Thoracic Society as well as the Global Initiative for Chronic Obstructive Lung Disease. Both of these are available as links from the module. One thing that you'll notice is the primary focus of this lecture will use the GOLD criteria for defining and managing COPD. The reason for this is it's a global strategy for the diagnosis, treatment, and prevention of COPD, and the guidelines were updated in 2006. It's a worldwide panel of experts, including representation from the American Thoracic Society. So one would think that since the American Thoracic Society was at the table for the GOLD initiative, that their opinions would also be reflected in the statements of this group. So rather than trying to divide and conquer and focus on the differences between the two guidelines, I'll probably maintain my focus on the GOLD guidelines for the purposes of this course. But if you're working in a pulmonary setting in your practice, it's probably worthwhile for you to be familiar with both sets of guidelines. So let's get started with a definition of COPD. And before I do this, I wanted to point out that some of these slides are taken directly from the GOLD teaching slides at the website listed at the bottom of each slide. Again, an important example on how treatment guidelines often have teaching slides associated with them that are for public use. So as you're doing teaching as well in your futures, please take advantage of those types of slides that are available. So to define COPD, it's a preventable and treatable disease with some significant extra pulmonary effects that may contribute to the severity in individual patients. However, the pulmonary component is then characterized by airflow limitation that is not fully reversible. And I think this is a key take-home point. It's not reversible. It may be partially reversible, but you'll never have complete resolution of the limitation. The airflow limitation is also usually progressive and associated with an abnormal inflammatory response on the lung to noxious particles or gases. So you can see it's not reversible and it's usually progressive. That's where we get into the seriousness of this disease. I'm not going to read through each of the stages in detail, but wanted you to know that COPD is classified by spirometry into either mild, moderate, severe, or very severe disease. And you can see that the spirometry and the levels of decompensation correlate to what you would think of as mild, moderate, severe, and very severe. I included this chart in the lecture simply as an interesting illustration of what is changing with death rates in COPD. So essentially, in a nutshell, this chart is the percent change in age-adjusted death rates from 1965 to 1998 and is inclusive of the U.S. population only. You can see the years broken down on the bottom, and then on the left of the chart, you can see the proportion of the 1965 rate. So essentially, if you look at all of the death curves, most of them are going down, where COPD is on a very steep upward slope. So that's why so much focus is being put into the management of this disease. We recognize that it is a fatal and increasing disease. I think it's also important, even though we will be focusing on pharmacotherapy, to understand some of the risk factors for COPD that aren't related to medication. And the primary risk factor is tobacco smoke. And one of the learning activities in this module off of the readings link focuses on medications used for smoking cessation. So it's important as an adjunct to this lecture that you then go and read through that activity to learn about the medications for smoking cessation. Because if we can encourage patients to stop smoking with the tools that we have available, it would be the obvious hope that we'd reduce the incidence of COPD by reducing exposure to tobacco smoke. Other exposure to particles include dusts, organic and inorganic materials, indoor and outdoor air pollution. And finally, the risk factors on the right, lung growth and development, oxidative stress, gender, age, genetics, and so forth. This slide from the Gold Initiative teaching slides, I think, is a good illustrator on the chronic inflammatory process of COPD. The chronic inflammation can cause in small airway disease and airway inflammation, but it takes it one step further, and that inflammation then becomes airway remodeling and obstruction. In addition, down the right side, you have parenchymal destruction, loss of alveolar attachments, and a decrease of your elasticity. So combined, you have airflow limitation. And again, I'm not going to spend a great deal of time on this slide, but I thought it was a nice illustration on some of the differences between asthma and COPD. You can see that there's different cell lines affected, as well as different CD4, CD8 cells, and asthma causes bronchoconstriction, whereas COPD actually causes small airway physical narrowing and destruction of the alveoli. And the airflow limitation, as this graphic points out, is reversible in asthma, but irreversible and often progressive in COPD. I extracted two statements from the Gold Initiative to again emphasize the importance of smoking cessation. They basically state in the initiative that reduction of total personal exposure to tobacco smoke, occupational dust and chemicals, and indoor and outdoor air pollutants are important goals to prevent the onset and progression of COPD. I think this second statement is a very strong one. Smoking cessation is the single most effective and cost-effective intervention in most people to reduce the risk of developing COPD and stop its progression. So again, this is another emphasizing point for your patient that you're working with. The single biggest thing that they can do is stop smoking to reduce their risk or reduce the progression of COPD. And now that we have many tools available to us as far as pharmacotherapy and other non-drug alternatives with smoking cessation aids, I think this is something that as you work in primary care settings will be a pivotal role when you have prescriptive privileges, trying to get patients to really recognize the importance of smoking cessation. And one of the primary reasons why quitting smoking is so important is that it's been shown to reduce the risk for onset and reduce progression of COPD. That's more than we can say about any of the other medications that we have available for COPD. None of the existing medications have been shown to modify the long-term decline in lung function. So all we're doing with our current therapies is decreasing symptoms and complications. Many agents used to treat COPD that we're going to talk about in this lecture were covered in the asthma lecture, so I'm not going to describe their mechanisms of action in detail in this lecture, but if it's something that you don't remember from the asthma lecture, please go back and review the mechanisms of action of these agents. They're the same for COPD versus treating asthma. So we're going to now work through the classes of pharmacotherapeutic agents as they apply to managing stable COPD according to the Gold Initiative. So the first one that they address are the bronchodilators. And they state with a level of evidence A, and A is a very high level of evidence supported by strong clinical trial data, that bronchodilator medications are central to the symptomatic management of COPD. And you notice here that they state symptomatic management, reminding you that it's not going to decrease the progression of COPD. They are to be given on an as-needed basis or on a regular basis to prevent or reduce symptoms and exacerbations. The principal bronchodilator treatments that they discuss are the same ones that we mentioned in the asthma lecture, and those are the beta-2 agonists, the anticholinergic agents such as ipratropium and tiotropium, and we'll discuss tiotropium in this lecture since we did not cover it in the asthma lecture, and the methylxanthines used singly or in combination, again with a strong level of evidence. They also state that regular treatment with the long-acting bronchodilators is more effective and convenient than treatment with short-acting bronchodilators, and probably more likely to have your patient be compliant, as they'll not have to use the long-actings as many times a day as if they were using only short-acting. The next class of agents that they discuss are the glucocorticosteroids. And the GOLD criteria state that the addition of regular treatment with inhaled glucocorticosteroids to bronchodilator treatment is appropriate for symptomatic COPD patients with an FEV1 of less than 50% predicted value. So severe COPD and very severe COPD, and for repeated exacerbations. So you can see that the role of steroids in treating COPD is slightly different than in asthma. Where in asthma, you're probably going to introduce a steroid in a mild intermittent patient. Really, it's not until you get to the later, more severe stages of COPD where they advocate using a steroid in combination with the long-acting bronchodilator. And that just reflects, again, the differences in the disease states and how asthma, the key component is that reactive inflammation, and trying to suppress that reactive inflammation is essential to management. And that's why steroids are so good in asthma, where that's not necessarily the case in COPD, but in the later stage disease, you may see an added benefit. They also state that an inhaled glucocorticosteroid combined with a long beta-2 agonist is more effective than the individual components. So again, combination therapy is more effective than monotherapy. Really shouldn't be a big surprise there, as we're attacking separate mechanisms of action. As with your asthma patient, taking systemic oral glucocorticosteroids is not recommended by the GOLD criteria if you can avoid it. So they state that chronic treatment with systemic steroids should be avoided because of an unfavorable benefit to risk ratio. They do still state a role for steroid bursts in controlling acute exacerbations, however. So trying to avoid having your patient take chronic steroid therapy orally is your best bet, because that's when you get the more unfavorable side effect profile from corticosteroids. You're not going to get things like moon phases or HPA suppression from a short course burst, but you may have that, and probably will have that, on a long-term therapy. That being said, many COPD patients do wind up on chronic oral steroids simply because it is a progressive disease and there's really not much else we can do at the severe point to control their symptoms. We're not going to talk about the pharmacology or action of vaccines in this lecture. That will come later in the course. I did want to point out that vaccines are an important component of management of stable COPD. In COPD patients, influenza vaccines can reduce serious illnesses, and that's, again, a very high level of evidence. There's been clinical trials showing that patients are hospitalized less, patients have less comorbidities and less symptoms if they get influenza vaccines, and that's probably because we're preventing influenza in those patients. And influenza in someone without COPD can be bad enough, but if someone with an underlying lung issue like COPD patients develops a lung infection, you can see where that would be very detrimental. Another vaccine that's recommended is the pneumococcal vaccine, and it's recommended for patients 65 years and older, and for patients younger than 65 with an FEV1 of less than 40% predicted value. I think this is a nice chart summarizing, again, the medication therapy based on disease severity. You can read the classifications based on spirometry. We mentioned that earlier in classification of the disease as mild, moderate, severe, or very severe. So you'll want to be familiar with those values simply because you need to know how to classify a patient to know what medication is needed at that stage. So obviously you can see along the bottom of the graph that active reduction of risk factors is important, and the component of pharmacotherapy that goes along with that are your vaccines. And you can see across the board, all these patients should have a short-acting bronchodilator for rescue therapy. And as with asthma patients, they should keep it with them at all times. And you can see from stages 2 through 4, regular treatment with one or more long-acting bronchodilators and pulmonary rehab is recommended. And stage 3 and 4, or severe and very severe patients, should be on inhaled glucocorticosteroids if they have repeated exacerbation. I wanted to pull out the anticholinergics one more time, even though we did talk about ipratropium during the asthma lecture. I wanted to spend a little bit of time talking about tiotropium. As you remember with ipratropium, it is a derivative of atropine. It doesn't have very good systemic absorption when it's inhaled, and that's why we can deliver it in high doses. It doesn't get absorbed systemically, just locally. And what it then does is inhibit bronchoconstriction. Tiotropium basically has the same mechanism of action as ipratropium. However, it's a long-acting anticholinergic, where ipratropium would be classified as short-acting. So there is some benefit to using a long-acting agent like tiotropium, and that's adherence, and there's good clinical data. Since you only have to take the tiotropium one time a day, the likelihood of compliance is much higher, versus ipratropium is often dosed up to 4 times a day. Disadvantages of the tiotropium inhaler is that the inhaler itself may be difficult to manipulate, and I'll show you that on the next slide. The patients actually have to place a capsule into the inhaler device. And here you see illustrated the tiotropium inhaler, brand name Spiriva, and it's called a HandyHaler. You can see that there might be some issues with this for elderly patients who don't have the dexterity to manipulate this inhaler. You see in the picture below, it requires the placement of a capsule into a little hole. The patient then closes the inhaler, and there's a puncture of that capsule releasing the powder. And you can see to the right that then the patient inhales as if they would be inhaling any other inhaler or through a straw, a deep breath in. So it's something that if your patient doesn't have the dexterity or capability to understand an inhaler that uses multiple steps in order to deliver the medication, that's when you have to think twice about prescribing this agent. One thing that I just wanted to touch on, since most of our pharmacotherapy agents are for symptomatic control and none of them reduce disease progression, we're going to expect COPD exacerbations in most patients. So I thought we would touch on COPD exacerbation management briefly. An exacerbation of COPD is defined as, quoting the GOLD teaching slides, an event in the natural course of the disease characterized by a change in the patient's baseline dyspnea, cough, and/or sputum that is beyond normal day-to-day variations, is acute in onset, and may warrant a change in regular medication in a patient with underlying COPD. So obviously the key point is there's a change from baseline. The recommendations for treatment or managing these exacerbations include inhaled bronchodilators and oral steroid bursts. And those are the two things you should be thinking to treat a patient who has that change in baseline status that you then classify as an exacerbation of COPD rather than overall disease progression. Antibiotics shouldn't be used empirically, but it would be appropriate to prescribe an antibiotic if the patient has evidence of infection, such as a fever. These are patients who chronically produce sputum anyway, so it's oftentimes hard to use that as an assessment tool, but if you have other evidence of infection, antibiotics would be warranted for these patients, such as a chest X-ray indicating pneumonia, fever, as I mentioned, elevated white count, etc. But empiric use of antibiotics for COPD exacerbations has not been proven to be effective, and then you're also exposing your patient to an unnecessary medication and increasing the risk for antibiotic resistance in the future. I wanted to end in the last few slides of this lecture discussing some things that you may not see in references but are just more practical issues when thinking of prescribing therapy for COPD patients. One is the inspiratory drive. Especially with progressive disease, patients may not have that capacity to do a real strong inspiration. So depending on the type of inhaler device that they use, it may not allow for adequate delivery of the drug to the lungs. Use of a spacer device where the patient can more slowly inhale particles that are suspended in the spacer may be of assistance for your patient. And ultimately, they may come to rely on nebulized formulations when these formulations are available for the medications. Again, inspiratory drive for some inhalers, and we'll point some of them out in an upcoming slide, is what triggers the inhaler to release the medication. Just as important as having the inspiratory drive to trigger the inhaler for the dry powder inhalers, inhaler technique is imperative to assess, reassess, reteach, reassess. Like I mentioned earlier, even patients who've been using inhalers for years and years often fall victim to sloppy habits, and if you can't deliver the drug, then the drug isn't doing its job. In addition to assessing inhaler technique, it's important for you as a prescriber to know what type of inhaler you're dispensing. Is it a traditional aerosol inhaler, which is what most of us think of when we say inhaler? Is it a discus or a dry powder inhaler? Or is it one of those that have the inspiratory drive requirement that are breath activated? So those are the types of things that when you're going to write a prescription for an inhaler, make sure that you know what type of device that you're dispensing, since it's not just a traditional aerosol inhaler market anymore. And this slide is just illustrating some of the different types of inhalers. Down in the lower right, you see what we think of as a traditional inhaler. Basically an aerosol inhaler that the patient presses and a spray comes out the mouthpiece and they inhale. However, over the years, different types of delivery systems have developed. One of the big reasons for this is the mandate by the government to make inhalers chlorofluorocarbon free. So many of the traditional aerosol inhalers were reformulated and either came out as a powder or they're now CFC free in their aerosol. They have different vehicles that are being used. But these are some examples of devices that have been around for a while in the case of the discus and the dry powder turbuhaler, or are a little newer, as we talked about with the Spiriva powder capsule device. One thing to mention about the dry powder turbuhaler is that one is a breath activated inhaler, and one agent that's used or that uses this delivery device is budesonide, and that's a steroid medication. So if your patient doesn't have a strong enough inspiratory drive to activate the release of the drug from a turbuhaler, the drug isn't going to come out and be delivered. So that's the one where you want to consider inspiratory drive. The discus is usually patient-friendly once the patient realizes how to use it, and so after some initial teaching and counseling, most patients do okay with the discus type inhaler. It's not to say you won't see some creative inhaler techniques with it and have to reteach it. And we also talked about some of the limitations of the dry powder capsule device. One that I didn't mention on the earlier slide is please counsel the patients not to take the capsules orally. I've read cases reported where patients are mistaken about how to use the inhaler, and they inhale the device empty and swallow the capsule. So again, don't assume anything and make sure that you're reassessing inhaler technique in order to correct, redirect, and maximize how your patient's using their inhaler. Another practical issue is that of spacers. While it's not a substitute for good technique, it may help a patient with poor technique. But please don't assume that just because you're prescribing a spacer, everything will be fine. Patients can still misuse spacers, so I would still encourage you to reassess it every visit. But it sometimes helps patients who lack the dexterity to use an aerosol inhaler or the ability to time their inspiration with that of the output of the inhaler, and also with children. As I mentioned earlier in the asthma lecture, it may help with steroid-induced thrush by reducing that direct hit on the tongue. Right now, the spacers are only for aerosolized inhalers, so obviously powdered inhalers would not benefit from a spacer. And just know that there's numerous types of spacers available, some that are a little more easy for children to use, some that have masks, etc. So you would just have to choose one that would work best for your patient. And this is just a little cartoon again illustrating the importance of smoking cessation, how quickly and how easily you can go from hospitality on the left to hospitalization on the right. And with that, I'd like to thank you for your attention throughout this lecture and invite you to please post any questions about the lecture or any of the additional required reading materials on the Ask the Pharmacist link for this module. Thanks.